Hi, my name is Dr. Ruchir. I'm a sleep medicine specialist with formal training in sleep medicine with a background in internal medicine, but also special focus in neuromodulation therapies for sleep apnea as well as insomnia, but even mental health. Let's talk about sleep.
This podcast is brought to you by Sip to Sleep. SIP, the number 2, sleep. Sip to Sleep is an all-natural, patent-pending, clinically proven natural sleep aid without melatonin. It contains 2 natural ingredients, tart cherry extract, which has been shown independently in small clinical studies to improve the ability to fall asleep, stay asleep, and sleep longer, but without the natural sugars of the tart cherry juice. And then the second ingredient in Sip to Sleep is Venetron, which is rafuma leaf extract, which comes from Japan. It has been shown independently in clinical studies to improve the brain's ability to enter into stage 3 sleep, which is also known as deep sleep, but also reduces degradation of serotonin in the blood, which is a precursor to melatonin, but also helps to improve mood by virtue of having antidepressant and anti-anxiety effects. Both of these natural ingredients combined together actually help to facilitate increased natural melatonin production and release from our brains, which in turn helps to facilitate sleep. The clinical study that was run on Sip to Sleep, specifically in 2023, showed that greater than 80% of participants that took Sip to Sleep prior to bedtime found that they actually fell asleep faster, slept longer, felt better rested the next day when they woke up in the morning and during the daytime, but they also noted a reduction in next day anxiety as well when they took Sip to Sleep compared to not taking it. So if you're looking for an all-natural sleep aid that does not contain melatonin and does not have the negative long-term effects of prescription sleep aids, try Sip to Sleep. It's formulated by a sleep physician. It's available online at www.sip, the number 2, sleep.com. That's www.siptosleep.com. Hi, let's talk about snoring and sleep apnea. So snoring and sleep apnea are very common. They both go hand in hand. A lot of individuals think that if they snore but they don't stop breathing, that they don't have sleep apnea. A lot of people think that if they don't snore at all, that there's no way they could have sleep apnea. So as a sleep specialist, sleep apnea turns out to be probably the most common thing that we actually will see. And it's the most common diagnosis aside from chronic insomnia as well. But there's a lot of misunderstandings about sleep apnea in general. There's 2 main types of sleep apnea. There's obstructive sleep apnea, which is the one that's associated with snoring. And then there's central sleep apnea, which is not associated with snoring. And it's one that typically one doesn't know that they have. Even the bed partner may not notice it either, because it's a very unique type of sleep apnea where the brainstem, in essence, stops sending signal for the diaphragm to contract. So in essence, you don't take a breath when you're sleeping, but it's not because you had an obstruction in the back of your throat, but more so that the brain actually didn't send a signal for you to actually take a breath. Now, sleep apnea can present in many different ways. Like I mentioned, snoring is going to be the most common presentation of sleep apnea potentially. Now, not everyone with snoring definitely has sleep apnea, but there is definitely a high correlation in that up to 3 out of 4 people that snore to any degree, whether it's soft, intermittent, or loud, constant, that shakes the house, but up to 3 out of 4 people that snore to any degree, regardless of age, gender, body type, even ethnicity, can have underlying obstructive sleep apnea. Another misconception about sleep apnea is that you have to be overweight to have sleep apnea. Like I mentioned in one of my earlier podcasts, I've got sleep apnea. I diagnosed myself, almost 13 years ago, I believe, thanks to my wife reporting that I would snore and I was restless. And I didn't have any symptoms. And I'm a sleep specialist. And I asked myself my questions and I answered them all. And I truthfully did not think I had a problem. And I was not overweight when I diagnosed myself, nor am I even now. But needless to say, when I did my own test, it turns out I do have it. Now, one thing that went against me, actually, a couple of things that went against me were ethnicity. So, being of Indian origin from East India, we have a narrower throat structures, and Asians in general, we're at a higher risk just because anatomically our throat structures are narrower, so we're kind of more predisposed to potentially having it. B, my mother has a history of it. I suspect my grandparents likely had it as well. So it does run in families because of throat structure, and you inherit your throat structure and your anatomy from your parents and your grandparents. So it runs in families for sure. I have many, 2, 3, 4 generations that I take care of in my clinics that have sleep apnea, and even young children. Like I mentioned, I think in another podcast, even my young son, who's now 5, I diagnosed him with pediatric sleep apnea when he was 3 years of age. But in his situation, he had gotten really enlarged tonsils and adenoids, which in a child, those structures that are quite enlarged can really obstruct the airway. But the unfortunate thing for him, which I haven't told him yet, is that even though we cured his sleep apnea with tonsillectomy and adenoidectomy, unfortunately, because of my history and my mother's history, he's still predisposed to developing it again as an adult because of anatomy and inheritance. There's no gene per se for sleep apnea, but it's all tied to anatomy. Central sleep apnea usually is going to be more associated with other comorbid medical issues. So, central sleep apnea is much more common in individuals that have a history of heart failure, where the left side of the heart is not pumping strong enough, individuals that have had a recent heart attack, individuals that have irregular heart rhythms or arrhythmias like atrial fibrillation, individuals that take chronic opioid pain medications. That's one of the issues with chronic opioid use, even from a pain medication standpoint, is that opioids bind to the respiratory center in the medulla and the brainstem, and that in turn can actually induce central sleep apnea. It can be reversible if the pain meds are stopped. Now, we're also starting to see more central sleep apnea over the last couple of years, and we don't entirely understand why. We do suspect that maybe COVID had, some role to play, because we know that COVID actually infected the brainstem. Hence why, if you remember from the early days of COVID, one of the common symptoms was, decreased sense of taste or smell. Well, the area that of the brainstem that is responsible for sense of taste and smell is very close to the respiratory control center. So we're starting to suspect that many individuals that were infected with COVID, it may have resulted in a change in how the respiratory center and the brainstem controls our breathing. Because I've seen a lot of patients over the last several years where I'm reevaluating their obstructive sleep apnea. And when we do a new sleep study, it turns out they've got central sleep apnea that I was not expecting, and they never had it before. And they don't have the traditional risk factors for central sleep apnea, like the ones that I mentioned earlier. So the only commonality really was they'd all had, previous COVID infections. So it's an interesting phenomenon that we're actually seeing right now. Now, with obstructive sleep apnea or sleep apnea in general, what are the most common presentations? So, like I mentioned, snoring is one, but many patients will report that, I'm being told by my bed partner that I appear to be, holding my breath when I'm sleeping, or I'm waking myself up gasping, or, I'm just waking up a lot during the night, or I wake with a headache in the morning. I'm exhausted when I wake in the morning. I'm just tired during the daytime. I've seen patients with sleep apnea that will come in just reporting non-restorative sleep and daytime sleepiness. I've had patients with sleep apnea that come in reporting my spouse says I snore, but I just wake up a lot during the night, but I still feel rested when I wake in the morning and I don't feel tired during the day. So the thing about poor quality sleep in general, regardless of the cause, is that you don't have to have non-restorative sleep, or you don't have to wake up exhausted. You don't have to wake up tired. You don't have to wake up with a headache. You don't have to have daytime sleepiness or daytime tiredness, because like pain, we all have a different tolerance to poor quality sleep. Like I mentioned, I didn't have any symptoms that I could truly pinpoint. Now, in retrospect, now that I've been treating myself for all these years, I definitely can tell that by treating myself, I do feel better rested when I wake in the morning compared to when I don't treat myself, which is very infrequent. I definitely can tell that my cognitive functioning is sharper compared to when I don't treat myself. So that was kind of how I determined what my subtle symptoms were. But in the general population, a lot of people think that, oh, I have nothing wrong with me because I don't sleep poorly. I don't feel bad when I wake in the morning. I don't feel tired during the daytime. And that doesn't mean that you can't have sleep apnea. It's like hypertension or high blood pressure. Most people that are diagnosed with hypertension or high blood pressure, it's not because they went into their primary care doctor's office saying, "Hey, I feel like my blood pressure is elevated." It actually was determined when they went in to have a visit with their physician and their blood pressure was checked. And that's when they noted that the blood pressure was elevated. Now, some people with elevated blood pressure may present with symptoms, but most commonly it ends up being kind of an incidental finding. But then after it being repeated, we determined, gosh, you know what? It looks like you actually have hypertension, and we treat it. And we don't treat it to necessarily help you feel better, but we treat high blood pressure to prevent long-term complications that can occur with having untreated hypertension. And the same concept even applies to sleep apnea as well. And I'll get into that in a little bit. Now, other presentations of sleep apnea, which are very unique, are people can present with symptoms of insomnia, but that insomnia can actually be triggered by the sleep apnea. So it's also important to note that about 25% of people with obstructive sleep apnea actually never snore. So, yes, you can have sleep apnea and not snore at all. We see this a lot more in women and women that are not overweight. I've had many women present with just symptoms of very disrupted sleep, meaning that they're waking up a lot during the night, or they just feel like they're tossing and turning. They're not getting good sound sleep. And then, though they're sleeping 7 to 8 hours, they're waking up exhausted and they're sleepy all day long, meaning that they could take a nap at any time during the daytime if they had the time to do so. They don't have any other symptoms. They don't snore. They don't wake up gasping. Their spouses or bed partners are not reporting that they're holding their breath. They don't wake up with headaches. They don't have any other symptoms like that that would suggest that, hey, this person definitely has sleep apnea. But when we end up doing a sleep study and observe them sleeping, it turns out most of these individuals over the years that I've diagnosed have moderate to severe non snoring obstructive sleep apnea. And when we treat them, they end up sleeping more soundly through the night. They wake up feeling rested. Often they go from sleeping 8 to 9 hours per night. Now they're actually getting better quality sleep. So they're actually now getting maybe 7 to 8 hours of sleep. Though they're sleeping an hour less than they were before, they actually feel better rested and they feel better rested throughout the day as well. So snoring is merely just a sound of vibrations, right? So the best analogy I give patients is that the old whoopee cushion, right? You fill up air in the whoopee cushion, squeeze it out, and that rubber vibrates and it creates that vibration or that farting sound, so to speak, right? Imagine snoring to be a similar concept. We go to sleep, all the muscles in our body relax. The tongue's a large muscle which curves down into the throat. You've got your soft palate, you've got extra soft tissue in the back of your throat. And as you're sleeping and air is passing through, that soft tissue vibrates. And that's the sound of snoring. But if you don't have extra soft tissue kind of flapping in the wind, so to speak, you're not going to necessarily snore. But it's not the snoring that's causing the issue. The snoring is just merely a clue that there's excess soft tissue in this person's throat that could potentially be obstructing the airway. Now, the bulk of the reason for a person having an obstruction is actually the base of the tongue and the soft palate. So you go to sleep and everything back here will just gently collapse. Now, either it could completely collapse, which is when you have a full obstruction or an apnea. That's when a person may wake themselves gasping, or their bed partners may say, hey, you were holding your breath last night, and then I heard you gasp all of a sudden. Most of us, however, will not experience that, nor will we have that full level of closure. We'll see that more commonly in overweight individuals or individuals that have just a very narrow, tight back of the throat, even individuals that have large tonsils in adults as well. But majority of us that have underlying obstructive sleep apnea will have what we call in sleep medicine a hypopnea, which is just a partial closure of the throat. But if that partial closure is enough to where it prevents you from taking a full breath in, then you keep getting repetitive drops in oxygen, right? And obviously that's not healthy. Our normal oxygen during sleep should be 88% and above. Now, if we get repetitive drops in oxygen below that, even to that level, but below that, even greater, so is going to result in a significant burst of adrenaline. Because anytime the body detects that there's a drop in oxygen, its immediate instinct is to switch on that fight or flight response mode to be able to get blood circulating quickly. So, what happens is that you get this huge surge of adrenaline, the heart speeds up all of a sudden, your blood pressure rises a bit, in effort to kind of protect cells throughout the body and to start delivering oxygen as quickly as possible. But none of that should actually occur when we're sleeping, right? Sleep is a time when the parasympathetic nervous system or the rest system is actually activated. Sleep is a time when the body is supposed to regenerate itself, repair itself, and heal. It's not supposed to go into this fight or flight response mode while we're sleeping. So that kind of lends into all the negative issues that can occur with sleep apnea. Every time you get repetitive bursts of adrenaline during sleep, it can actually strain the heart quite dramatically to the point where it can increase the risk of left ventricular strain, meaning the left ventricle, the left bottom chamber of the heart, which is what's responsible for pumping fresh blood throughout the whole body. It can start to thicken up. And the reason for it is that every time you get that burst of adrenaline, the left side of the heart, or the whole heart for that matter, but the left side of the heart obviously is beating faster. But at the same time, that adrenaline release causes a temporary spike in blood pressure. Now you're forcing the heart to beat faster against increased resistance so that left side of the heart can start to thicken. And there actually was a clinical study that was published roughly about 10 years ago showing that in newly diagnosed obstructive sleep apnea, that over 60 to 70% of these individuals, when they actually had a 2D echo, which is an ultrasound of the heart, they were found to have evidence of left ventricular hypertrophy, even though they did not have a history of high blood pressure. Typically, we'll expect to see LVH or left ventricular hypertrophy in individuals with known hypertension, because again, the heart is beating against increased resistance. So, just like lifting weights, over time, the heart muscle is going to thicken. Now, we don't want that to happen in the heart. It's okay to have your biceps thicken when you're obviously lifting weights, but we don't want that to happen with the heart, because what ends up happening is that it ends up reducing the chamber of the left ventricle, and that in turn can result in all sorts of other issues down the road. So that's one problem that can happen with untreated sleep apnea. Another big one is every time you get that sudden burst of adrenaline, it can trigger the heart to go into irregular heart rhythms like atrial fibrillation. Now, statistically, we know from about, gosh, again, 10, 15 years ago, that having untreated sleep apnea is an independent risk factor for development of atrial fibrillation. And a person with untreated sleep apnea can be 3 to 4 times more likely to develop atrial fibrillation compared to an individual that does not have sleep apnea. Also, statistically, up to about 70 to 80% of people with a history of atrial fibrillation actually have underlying obstructive sleep apnea. So there is a very direct correlation between the two. And we see a lot of patients in our clinics that are referred by cardiologists with a history of new onset atrial fibrillation or recurrent atrial fibrillation. And their immediate question is, please evaluate this patient for sleep apnea. If a person has sleep apnea in the setting of atrial fibrillation, having that untreated apnea can keep that atrial fibrillation active. It can cause ablations to fail. It can cause cardioversions to fail. It can cause medications to not control the atrial fibrillation. I have one electrophysiologist who's, a rhythm specialist with the heart here in our Phoenix metro area that I've worked with now for, gosh, nearly 12, 13 years, who often would delay an ablation for an atrial fibrillation patient if I diagnosed him positive for sleep apnea, because he wanted their heart to be settled down by treating the sleep apnea first for at least 2 to 3 months. And then let's see what happens with the atrial fibrillation. I've seen patients where their atrial fibrillation actually reverted back into normal rhythm, or the heart reverted back into normal rhythm after we treated the sleep apnea. But the concern with atrial fibrillation, of course, is that it can increase the risk of stroke, because the top chambers of the heart are basically beating too fast and blood ends up churning, and that can increase the risk of coagulation or blood clotting. And then that's the last thing we want to happen, because if a piece of that clot breaks off, that can then get shot into the brain, and that can cause a major stroke. So we don't want that to happen. Now, other potential issues that can occur with sleep apnea is the repetitive drops in oxygen can also damage the electrical wiring system of the heart, which in turn can actually increase the risk of developing low heart rate. We see a lot of patients referred to us by cardiologists that when they do a Holter monitoring, which is they'll do continuous recording of the electrical system of the heart at home for 24 hours, 48 hours, even 30 days, and they'll find that when they're reviewing the data, that they're noticing that when the person is sleeping, that they're having, either very low heart rate, and by definition, during sleep, bradycardia or low heart rate during sleep is having a sustained heart rate less than 40 beats per minute. Or they'll find that they're actually having pauses in their heart rate, meaning that they're for 2 to 3 seconds or longer, there's not basically a heartbeat. So they'll refer those patients over. Other patients that end up having low heart rate even during the daytime will be referred over as well, because we know that having the repetitive drops in oxygen can actually damage the electrical wiring system of the heart, which in turn can cause low heart rate. And these individuals may end up having to get a pacemaker. But again, that can be caused by untreated sleep apnea. Untreated sleep apnea can also increase the risk of developing hypertension. It can actually increase the chances of a person with hypertension developing what we call resistant hypertension, where it takes more than 2 to 3 blood pressure medications to control that blood pressure. And the recommendation from the Joint National Commission, the JNC, which is the group that develops the guidelines on management of hypertension, they've recommended for years that if a patient has resistant hypertension, that they need to be evaluated for sleep apnea, in addition to a bunch of other medical problems that could potentially contribute to why that individual has difficult to control hypertension. So I hope that kind of gives you an idea in terms of what the negative, cardiovascular risks are with having untreated sleep apnea. Others can be increased risk of cardiovascular disease, increased risk of blockages. Having untreated sleep apnea can increase risk of heart attack by 2 to 3 times. It can increase the risk of stroke by up to 4 times. And there was a paper initially published out of Yale, I believe, in 2015 that did a retrospective analysis, and they found that 70% of patients that had a stroke, whether a TIA or a major stroke, that up to 70% of stroke victims actually had underlying obstructive sleep apnea. And that data has been subsequently duplicated at other centers as well. And I believe it was in 2016 or 2017 that the American Heart Association and the American Stroke Association actually updated their stroke treatment and prevention guidelines to actually include rule out sleep apnea in a patient with any kind of stroke, right? Whether it's a TIA, an ischemic stroke, which is where a blood clot blocks off a vessel, or a hemorrhagic stroke, which is where you actually end up getting a brain bleed. The most common stroke, of course, being an ischemic stroke, which is the result of a small blockage. But the recommendation for nearly 10 years now is that if a person has had a stroke of any sort, regardless of the presence or absence of any other risk factors, you have to rule out sleep apnea as a potential contributor, because sleep apnea can obviously contribute to development of all those other risk factors that we already know for years can contribute to developing a stroke. Now, that's the cardiovascular stuff in terms of what untreated sleep apnea can cause. But there's so many other issues that untreated sleep apnea can create as well. There's a large link between appetite regulation, metabolism, and even weight control when it comes to poor sleep in general, but even sleep apnea especially as well. So, in the setting of untreated sleep apnea, because of the poor quality sleep induced by untreated sleep apnea, this in turn can actually cause hormonal dysregulation, where it actually can cause an individual to gain weight, even though they're trying to lose weight. An individual can actually gain weight, and it's hard for them to control, you know, how they're managing their weight. And it's not because they don't have the willpower to lose weight. It's actually a hormonal issue that's developed. So there's a series of hormones in the body that actually help us to kind of regulate our appetite and help to control how much we eat, what kind of foods we crave. There's only one hormone in the body that actually promotes us to gain weight, and that hormone is produced from the stomach called ghrelin. And there's a series of other hormones that are produced throughout the intestinal tract that actually are trying to counteract that one hormone. In the setting of poor quality sleep, whether it's untreated sleep apnea or any other source, especially sleep deprivation, but especially in the setting of untreated sleep apnea, if the brain is not getting good restful sleep, what ends up happening is that the stomach starts releasing higher levels of ghrelin. What ghrelin does is that it speeds up transit time through the stomach. So what that means is that every time you eat, the stomach ends up contracting faster. So you get increased peristalsis, which in turn transfers food from the stomach into the small intestine much faster. Now, one of the control mechanisms for appetite regulation in the stomach is their stretch receptors. And what that means is, imagine your stomach is like a balloon, right? So when the stomach, you're feeding yourself and the stomach fills up, it eventually reaches a breaking point where it activates those stretch receptors and it sends a signal back to the hypothalamus, which is where our appetite regulation control center is. And once those stretch receptors are activated, it sends a signal to the brain saying, hey, I'm full, stop eating. But the problem with ghrelin is that it keeps the stomach contracting faster. So it ends up pushing the food out of the stomach into the small intestine. So what ends up happening is that the stomach can't ever fill up quick enough to activate those stretch receptors. So what ends up happening is that the consumption of food, the volume of food that we eat, just gradually goes up and up and up. So what that means is our caloric intake increases, right? So that in turn basically results in us eating more and more. And it doesn't go from eating, you know, half a bowl of pasta and then overnight you're eating a full bowl of pasta. It's a gradual increase. So you don't really realize that you're having this increased consumption of food, but it's just this gradual increase of, calories that you're consuming because you're not feeling full as early as you used to. The other issue with ghrelin is that it travels to the ventromedial aspect of the hypothalamus, which again is the appetite control center, and it actually increases cravings for comfort food, right? We're all guilty of, when we're tired, exhausted, we crave comfort foods, right? Drive through, pizza, whatever it is. But ultimately, ghrelin is what's largely playing a role in this. It's actually increasing our cravings for sugars, carbohydrates, fatty foods, and it's promoting this. So when you're not getting good sleep or you have untreated sleep apnea, there's just this constant high level of ghrelin that's promoting the consumption of these unhealthy foods, which again are high caloric foods, which promote weight gain. But then on top of it, like I mentioned earlier, your stomach can't ever stretch quick enough to get you to stop eating sooner. So that in turn, you're eating a higher quantity over time of these much more unhealthy foods. So that ends up promoting weight gain. And then finally, ghrelin ends up blocking the healthy hormones that help us to lose weight, i.e., by helping us to reduce our consumption of unhealthy foods, slow down contraction stomach. Ghrelin ends up blocking these hormones from actually binding in that hypothalamus appetite regulation center. So a lot of the medications that we have for weight control, like Ozempic, Wegovy, Mounjaro, a new one called Zepbound, those are actually these molecules, right? GLP-1, which is glucagon-like peptide 1, and then even GIP, which is what's the combination in Mounjaro and Zepbound. These are actually two of those hormones that I'm referring to that actually help us to lose weight by virtue of reducing that cravings for the unhealthy foods, but also slowing down contraction in the stomach. So having the opposite effect of what ghrelin does and helping us to actually feel full much quicker. So what ends up happening is our caloric intake or our quantity of food consumption gradually declines, and that's what's helping us to lose weight, right? But one thing that I always educate my patients is that you could take these medications and lose weight, but the challenge is if you're not getting good quality sleep, you're not doing yourself as much service or you're doing yourself disservice, if anything, because if you were to potentially get better quality sleep, you may be able to better regulate your weight with even less medication, or you may not even need some of this medication, right? Or in people that are taking the medication, they may not be having the effect that they want because, again, they're not getting good quality sleep. So sleep and metabolism and weight regulation go hand in hand quite significantly. So I hope that kind of better explains how sleep and sleep apnea are tied into, our metabolism and our control of weight. Now, untreated sleep apnea also has been shown to greatly impact mood as well. So there was actually a paper published several years ago in the psychiatry space showing that up to 50% of individuals, or if not greater, of individuals with treatment resistant depression or major depression actually had untreated sleep apnea. There's also research that's come out from the VA and vets showing that vets that have a history of severe PTSD and depression, up to 70% of these individuals actually have underlying obstructive sleep apnea. What's the correlation? Well, the correlation is that untreated sleep apnea, because again, every time the brain detects that you're not taking a normal breath, the brain's going to quickly wake up in the background for 3 to 4 seconds to get you to take that normal breath. That ends up basically disrupting the normal sleep progression, right? And the whole mechanism of action is that every time the throat collapses, if you can't blow out your CO2, that spike in CO2 is what triggers the brain to want to wake up in the background and get you to take a normal breath because the brain can't change the way we breathe and keep us asleep at the same time. So the brain has to disrupt sleep for 3 to 4 seconds, get you to take those normal breaths. The brain goes back to sleep. All the musculature relaxes again, and this whole process occurs all over again. So anything that triggers the brain to wake up more than normal will end up shifting the brain to spend more time in stages 1 and 2 sleep, which is light sleep, and less time in deep sleep, which is stage 3, which is where growth hormone is released. That's what helps our bodies to regenerate themselves. But also, you're not getting enough REM sleep, which is where we dream. That's the key. So, in the setting of decreased REM sleep, there's been a lot of research in the last few years showing the bidirectional relationship between sleep and mental health. And I think I talked about this in another podcast where not getting enough REM sleep actually can increase the focus on negative emotions and it causes the frontal lobe to overlook positive emotional states. So there's a direct correlation that not getting enough dreams or REM sleep actually impacts how the frontal lobe is going to respond to emotional stimuli and emotional stressor, so to speak. But the amygdala in the brain will also become more hyperactive. So there's increased chances of developing irritability, increased anxiety. So that's how it can actually impact mood control and affect those individuals with major depression. So one of the recommendations is, and has been for a number of years, that individuals with treatment resistant depression, they should be evaluated for underlying sleep apnea as well, because if sleep apnea is present, treating it can help to normalize the quality of sleep, increase the brain's ability to get into REM sleep, improve functionality of the frontal lobe, which in turn can help the individual with mood regulation and help the depression. In the setting of PTSD, when a person is not getting enough REM sleep, or sleep is very broken. Anecdotally, patients will report, even without PTSD, patients will report, I just have a lot of bad dreams, a lot of, a lot of nightmares that are just, I don't understand why I'm having them. In someone that has a history of PTSD, having untreated sleep apnea, having that decline in REM sleep will actually end up increasing periods of time where the brain is trying to recover lost REM sleep, but it actually causes an increased recurrence of those nightmares from the traumatic events. So there's, again, a direct correlation there as well. And we've seen a lot of patients over the years, whether they're vets or non-vets that actually have a history of trauma and PTSD, that once we improve their quality of sleep by treating their sleep apnea, that their PTSD symptoms actually improve, nightmares almost resolve, but even their heightened sense of awareness and their heightened anxiety and triggers during the daytime can actually improve as well, because by virtue of increased REM sleep, like I mentioned, there's hyperactivity of the amygdala. So by getting increased REM, you lower the activity in the amygdala. So that in turn helps to reduce anxiety and irritability as well. So there's a huge, huge impact on mood regulation cognitively. Huge impact with untreated sleep apnea. Having untreated sleep apnea, first off, because of the poor quality sleep, can certainly impact our short-term memory and concentration, right? When we're tired, we all have noticed that we don't think as clearly. We have brain fog, like a lot of people report. We have a tendency to forget things more regularly, almost mimic like an ADHD type kind of symptomatology, right? Even I'm guilty of it as well, because that's one of the things that I noticed about myself is that once I started treating myself and getting better quality sleep, I started noticing that, gosh, you know what? I feel like I'm mentally sharper, I'm thinking faster, I'm more efficient at reading sleep studies or doing, my clinic, and I'm much more rapid in terms of my overall thought process. Not that I was sluggish like I was floating in molasses, but still I noticed that there was an improvement. But there's another concern. Having untreated sleep apnea in the last 10 years actually has been shown to increase the risk of development of dementia, whether multi-infarct dementia, which is the result of series of repetitive mini strokes that don't cause any physical symptoms, but start killing off enough white matter to where individual develops dementia down the road, but even Alzheimer's disease. So I believe it was in 2017, 2018, the Alzheimer's Disease Association, they had a meeting in London, and they presented at that time that having untreated sleep apnea, obstructive sleep apnea, is a major risk factor for development of Alzheimer's disease. And then this finding has been further duplicated over the course of the last 5 years. The reason being is that in 2013, there was a paper published by a group in the University of Rochester showing that during stage 3 sleep, there is basically a system called the glymphatic system, which washes out toxins, of metabolism from the brain, including the beta amyloid protein, which all of our brains produce. But in the setting of poor quality sleep, you don't get enough stage 3 sleep, i.e., sleep apnea induces the same phenomenon. You're not washing out those proteins, so those proteins build up, and that in turn ends up causing the deposition of these proteins in the white matter, which can contribute to Alzheimer's disease. In the setting of sleep apnea, it's almost a double whammy. The repetitive drops in oxygen can actually increase the release of beta amyloid protein. The poor quality sleep induced by untreated sleep apnea, i.e., not getting enough stage 3 sleep, prevents the glymphatic system from operating, which in turn can't wash out this protein, right? So it inherently builds up, and that in turn starts sticking in the white matter, almost like tartar between your teeth. And it ends up disrupting the normal, neuronal pathways that help to regulate memory and executive functioning and all that. And that's contributing to Alzheimer's disease. So we know that statistically, having severe untreated sleep apnea, an individual is 4 times more likely to develop Alzheimer's disease compared to an individual that does not have obstructive sleep apnea. So that's a huge major concern. And there's findings showing that when you treat a person successfully with CPAP therapy, it may slow the progression of Alzheimer's disease development as well. So huge correlation there. Now, let's quickly talk about testing. How do we diagnose people with sleep apnea? So the classic way of diagnosing sleep apnea, and the gold standard, is actually doing an in-lab sleep study where a person comes into the sleep lab. We're connecting them to multiple different monitoring equipment, including EEG, where we're monitoring brain activity to be able to see when they're awake, when they're asleep, when the brain wakes up. A breathing sensor in the nose and above the mouth that monitors breathing patterns to be able to see, are you having complete cessation of airflow or partial cessation of airflow? There's an oxygen sensor, microphone for snoring, EKG to look for regular heart rhythms, a belt around the chest and the abdomen that measure breathing effort, muscle tone sensors on the legs to see if you kick or twitch to look for what we call periodic limb movements, and a video camera in case you talk or walk. Otherwise, the video is pretty useless. And sleep technicians there as well. So that's the real official way and the gold standard way of diagnosing sleep apnea, because we can truly see when a person's awake and asleep, and then we can directly correlate if the individual is having subtle sleep apnea events that doesn't cause a drop in oxygen, but actually disrupt sleep. The most more common way of diagnosing sleep apnea, which largely has become driven by insurance companies over the last 10 years, is home sleep apnea testing. Home sleep apnea testing is not the same as in lab sleep testing. There's a large misconception amongst patients and non sleep physicians that home sleep apnea testing is a duplicate of what we do in the sleep lab, and it's not. There's no way. And the reason being is that home sleep apnea testing, the most we can do is monitor airflow through the nose, breathing effort through a belt around the chest, oxygen sensor. There's some devices that actually are looking for sleep apnea events by monitoring pulse and changes in the arterial tone in the fingertip. There's some that actually monitor breathing and give you kind of an airflow correlation by measuring breathing effort. But none of these devices are actually truly recording sleep. There's some out there that you wear on your forehead and they kind of give you a surrogate of sleep, but we still can't truly analyze the brain activity like we do during an in-lab sleep study. So a lot of this breathing data that we're recording at home, we're making a large assumption that the breathing deficiencies that we're seeing when we're reviewing the raw data, it's occurring during sleep, but we cannot truly confirm. The other factor is that if the sensors weren't applied appropriately by the patient, it may not fully record all the information correctly, so we may miss information. So with home sleep apnea testing, it's very important to note that they are not the same as an in-lab testing. There is a higher false negative rate with home sleep apnea testing, and which is another unfortunate reality is that a lot of patients are being told by inexperienced sleep physicians or non-sleep physicians, whether primary care or cardiology or other specialties, that if your home sleep apnea test did not show sleep apnea, that you don't have it. It's so extremely important to note that if you've had a home sleep apnea test and it did not show sleep apnea, it does not exclude the potential of you still having sleep apnea. You cannot exclude the presence of sleep or the absence of sleep apnea with a negative home test, or we call it technically an inconclusive home test. If there's symptoms suggesting, or if you have risk factors for sleep apnea, such as hypertension, heart disease, atrial fibrillation, history of stroke, obesity, diabetes, severe depression, PTSD, if you had a home test or you just suspect that you're not getting good quality sleep or you snore, if you suspect or if we suspect that this person may have an underlying sleep apnea, but they had a home test done first that did not show it, then the next recommendation is to do a formal in-lab sleep study, which is a more in-depth analysis. Best kind of analogy is an X-ray versus a CT scan, right? Often you come in presenting of cough or other symptoms. We do a chest X-ray first because it's cheaper for the insurance company. The chest X-ray doesn't show anything. We can't say there's nothing wrong with your lungs because the chest X-ray didn't show anything. So often if we're suspecting that there's potentially something more significant going on, then we do a CAT scan, right? A CAT scan takes more in-depth images of the lungs to give us a better picture. So same analogy, a home sleep apnea test is basically a screening test. And if it doesn't show anything, it doesn't confirm that there's not a problem. But then we have to do the more in-depth test, which is going to be the in-lab sleep study. So that's always something very important to know is that if you suspect that there's a problem and you have a home test because it was driven by insurance or that's what your doctor ordered, if it doesn't show anything, then if they don't recommend it, push for a formal in-lab sleep study because that's the gold standard test, not a home sleep apnea test or a home sleep test, as we also call it. Now, finally, let's wrap up with treatment. So, multiple ways to be able to treat sleep apnea, right? The gold standard way of treating sleep apnea is going to be CPAP therapy, which stands for continuous positive airway pressure. It was developed in the mid 80s. It's been the gold standard treatment since that time. It's the only thing that's almost 100% effective to treat all levels of sleep apnea because it's pressurized air. It's not forcing anything into you or into your lungs, which people think. It's not delivering oxygen. Basically, it's a little vacuum, a compressor, and a humidifier. So it pulls air in from the room, pressurizes it, humidifies it. As you're breathing with it, it's like an air splint. It just holds the throat open, right? So at the correct pressure, there should be no more snoring. Full breaths in, no more drops in oxygen. Full breaths out, no more excess issues with CO2 retention. So you're fully releasing your CO2. So now there's no trigger for the brain to wake up. And that's how it improves quality of sleep. Yes, I will be the first to admit it takes time getting used to it. There is, unfortunately, a negative stigma of using CPAP therapy. But ultimately, once you get used to using it, you're working with an experienced sleep physician or a sleep practice that knows how to troubleshoot quickly and help to get you through those hurdles that a lot of people experience with CPAP therapy, or they know other alternatives like BiPAP therapy, then it's easy to get into a routine of using it. And then once people get into a routine of using it, like I have now for 13 years, I won't sleep without it because one night of not using it, I can tell a difference. Now, there are some people that can't tolerate CPAP, whether because of claustrophobia or they can't keep their mouths closed with the nasal mask, but they're not working with someone experienced enough to say, hey, you know what, let's try XYZ or let's try something different. There's an oral appliance that can be also fabricated, which is made by dentists. There's custom fabricated oral appliances. There's even over the counter boil and bite ones. But in essence, the premise is that it's fitted to top and lower teeth. And the lower portion is basically locked forward. So we're trying to extend the mandible forward to prevent the jaw from collapsing backwards. So we're trying to keep the base of the tongue from being, collapsing backwards as much. Now, they're not 100% effective, right? Because you can only hold a person's mandible forward because we're limited by our TMJ in millimeter increments, right? There's risk of potentially triggering TMJ issues, slip disc, which happened to me. But the other thing too, there's also a lot of debate out there, amongst physicians, especially ENT, is that, well, it's not normal to keep your jaw held forward like that for 6 to 8 hours at a time. So there's a lot of, potential concerns that may happen. Now, I have a lot of patients that are successful at using oral appliance. So it's not that it can't work. It's just you have to work with an experienced dentist and sleep physician together to make sure that A, it's fitted correctly, it's not causing unnecessary strain or shifting of your teeth, which can happen, but it actually is truly successfully controlling your sleep apnea. Another new age way of treating sleep apnea for patients that can't tolerate CPAP is going to be Inspire therapy, which was FDA approved in 2014. I've talked about it before in another podcast, but basically, briefly, it's what we call a hypoglossal nerve stimulator, where in essence, there's an implant that's placed by ENT. There's a little, stimulator cuff around the nerve that controls two muscles below the surface of the tongue. In essence, every time you're breathing in, it activates that nerve to contract those two muscles to proactively pull the base of the tongue forward and pull the soft palate forward. So we're proactively opening the throat every time you breathe in. That can be anywhere from 70 to 85% effective in moderate to severe cases of sleep apnea. It's a very lengthy process, but it can be very successful for the right patient. Other alternative therapies can be positional therapy. There's some people out there that only have sleep apnea when they sleep on their back, which because of the gravity perpendicular to the ground, yes, sleep apnea in general will be more frequent and more severe on your back, but some people don't have much sleep apnea on their side. So we can sometimes recommend positional therapy. It can be challenging to sustain that long term because sleeping on one side or the other can result in excess strain on your shoulder joints or your hip joints. So a lot of people will end up developing arthritis, which then ends up over time causing them to have to sleep on their back. Weight loss is one that we always get questioned about. Well, if I were to lose weight, will it resolve my sleep apnea? And the short answer is it's unlikely to completely resolve the sleep apnea, but it can certainly help. And the reason being is that if we were to lose 20, 30 pounds, where's the bulk of that excess weight being lost from? It's not in the neck or the throat. It's going to be below the neck in the midsection, right? If your throat doesn't open up dramatically by virtue of that weight loss, well, it's not going to have a major impact in terms of completely resolving the sleep apnea, but it certainly can definitely improve it, right? So, and we've seen a number of patients over the years where they lose weight and they do have improvements in sleep apnea. But on the flip side, I've had patients undergo bariatric surgery where they've lost up to 100 pounds, 120 pounds is the most I've seen. And I had a copy of her baseline sleep study. We repeated her sleep study. She went from severe sleep apnea to severe sleep apnea. Numerically, yes, the frequency of the sleep apnea events reduced by almost 50%, but she still didn't have resolution of her sleep apnea, though she lost 120 pounds, right? So that's the most common phenomenon we'll see. So there is a misconception that losing weight will cause your sleep apnea to go away, and it's not true. It can certainly improve it, and in turn may certainly help to lower the CPAP pressure, or it could potentially open up the potential of using alternate therapies for milder cases of sleep apnea. But it's not ultra common that one will lose The one will have complete resolution of sleep apnea when they lose weight. So I hope this all is very informative and helps you to kind of get a better understanding that sleep apnea doesn't have to be your classic overweight male that snores, stops breathing, is gasping for air, waking up exhausted, falling asleep driving the car. That sleep apnea can actually affect any of us, right? Up to 3 out of 4 of us that have sleep apnea, like I said, of any ethnicity, weight, age, gender, any of us that snore, 3 out of 4 of us will have sleep apnea. 25% of us that have sleep apnea don't snore. Up to 50% of people with moderate to severe obstructive sleep apnea actually have a normal body mass index. So it's not predominantly in overweight individuals. About 40% of people with sleep apnea, in fact, turn out to be women. And a lot of women that present with sleep apnea symptoms or actually present with sleep apnea end up presenting with symptoms of daytime fatigue, non-restorative sleep, very disrupted sleep. Postmenopausal women can often present with difficulty falling asleep. So they present with insomnia symptoms, but it turns out that it's subtle sleep apnea that's actually triggering the insomnia. So, point being is that even though we in sleep medicine get a bad rap for we're always looking for sleep apnea, the truth of it is that unfortunately, sleep apnea can present in so many different subtle ways that it can present with a multitude of different atypical sleep symptoms that we have to rule it out because it's such a significant medical disorder that's more serious than just having hypertension. It's more serious than even having diabetes, in my opinion, because it can contribute to both of those, but it can contribute to atrial fibrillation, bradycardia that results in a pacemaker, heart failure, heart attack. It can result in stroke. It can result in pulmonary hypertension. It can actually increase risk of sudden cardiac arrest during sleep. So it's a very, very serious condition that has to be ruled out. And if we didn't rule it out, we're doing you disservice as your sleep physician. So hope this was helpful. If you have any concerns about any part of your quality of sleep, or if you just feel like, gosh, I feel like I could be resting better, go see a sleep physician and explore what could be going on. Thanks.